So today I have the pleasure of actually reintroducing Dr. David Moore. Dr. Moore is on the staff here at MGMC in McFarland. He's board certified in neurology, sleep medicine, and particularly germane to the topic today, epilepsy. And he has kindly accepted our invitation today to give us an update on epilepsy. And please join me in welcoming Dr. Moore.
Thanks, Steve. Nice to see everyone here this morning or afternoon. Find my thing to advance the slides. So we're going to talk about epilepsy and its classification, treatment options, but mostly we're going to talk about its classification. And I have a couple of questions to start out with. And so approximately the number of people with active epilepsy in the United States, including adults and children, represents what numbers? And this is a audience response question, just to see what people know about how common epilepsy is in the United States. And you can go ahead and answer now. And do I have to push a slide, Tim, to advance this to make it to find out what the answer? No. So there. The actual number is 3.4 million people in the U.S. have epilepsy. That would be 3 million adults and 444,000 children. And the last time this was taken was like 2010, and it was 2.3 million people. We think that the increase in number is due to population increases. So these are a couple of people having seizures. This is a man, and I want you to tell me if you think that he's having an epileptic seizure or non-epileptic, and then we'll look at the woman, and I want you to tell me if she's having epileptic or non-epileptic event. And we'll come back later in the talk and see if you are right or wrong. So we'll stop that. I'm going to play the guy again. All right. And then your answers. Oh, use 1 as A, 2 as B, 3 as C, 4 as D, and 5 as E if you don't have numbers on your... Let me back up and then go forward again. Tim, the numbers didn't show. Oh, there they are. One more time. So the man is non-epileptic and the lady is epileptic is what most people say. 30% say both. 15% say both are non-epileptic. 3% say the man is epileptic and the lady is not. Later on, I'll come back and tell you. What I want you to think about as we go on in the talk is why you think one is X and one is Y. Just ask yourself why one versus the other. All right. Next question is a question pertaining to anti-epileptic medications. These are all new anticonvulsants that most people here have not heard about, and so it's an unfair question. But I'm going to ask the question just because I can. It's kind of a match question in terms of which medicine goes with what symptom or what disease or what problem. The first one up there is Banzo or Refinamide and Lennox-Gastaut syndrome. The next one's Perampanel and visual loss. Its trade name is Vicompa. The next one is Ritagabine or Exagabine. Its brand name is Potiga. Does it make people turn blue? Vigabatrin, double vision. 5, all are true. 6, A or C are true. So it's an unfair question for multiple reasons. One is they outlawed K-type question. I guess this qualifies for a K-type question. And we only have 9 responses so far, so we'll go back. Let's go back. To here so people can look at them. I know that you don't know the answer, but you have to choose one. All right? This is one of those things in medicine where in medicine, if you don't know the answer, you still have to answer the question because that's what we do in medicine. So everyone re-answer now. You got 38, one more person, 2 more people. All right, we'll go ahead and advance. So the correct answer is A and C are true. Refinamide is approved to treat people with Lennox-Gastaut syndrome and Lennox-Gastaut syndrome-like symptoms. It's not approved for any other treatment. Perampanel does not cause visual loss. Vigabatrin causes tunnel vision or visual loss. Potiga, Ritagabine, Exagabine is being removed from the market because it makes people turn blue. It makes them become Smurfs. So that's the correct answer. All right. Let's talk about epilepsy history. And I'm going to throw in epilepsy history primarily because I just had this recent trip to the Congo. And it's amazing what people think around the world. But even more importantly, it's amazing what we still think about here in America, which is supposed to be civilized. So epilepsy was first recorded in the 5th millennium BC in the time of Mesopotamia, called the falling disease or Astanisbu. In the 1st millennium, they called it Bel-Ur, the demon god of the roof beams, because people's eyes would roll up looking at the roof beams and then they would fall to the ground. Hippocrates in the 5th century BC wrote the first definitive books about epilepsy in a paper called The Sacred Disease. And he talked about auras, differential diagnoses. He talked about idiopathic and symptomatic epilepsies. He talked about the influence of age, temperament, and menstrual cycle on seizures. Those things all have meaning yet today. And then in the biblical times, people brought people who had seizures to Christ, and he would heal them of their seizures. Now, what's important is that in Mark 9:17 through 20, actually, a man brings his child to Christ and asks Christ to heal him because his disciples could not, we find that interesting. When I was over in the Congo, people thought that there were witches, demons in people that made them have seizures. And they thought that people could get seizures from touching someone, from being bitten, or from their saliva, a variety of different things. And honestly, people still believe that today in the U.S. There's some data that we'll look at later on. So the first handbook came out in around 1494 when the Dominican priests basically killed 2,000 women because they thought they had seizures or were epileptics, and they accused them of being witches. Then the true modern era of epilepsy didn't start until 1861 with Hewlings Jackson's, followed by guys who replicated his work, Gowers, Timken, and Lennox. The first EEG came in 1929. It was a 4-channel EEG. We now use 24-channel routine EEGs. And in the OR, we'll use 64 disc, where you have 64 different contacts on a disc, and you'll put one of those on each side of the brain at times to monitor someone with epilepsy. So what is a seizure? A seizure is a clinical manifestation of an abnormal discharge of brain cells. And you'll have a group of brain cells that just fire on their own, and then you see that clinically. What's important about this is where those seizure cells are at, that discharge starts at in the brain, is the first thing that you would see in a seizure. Because of that, and in neurology, the whole idea of neurology is to first say, not what, or say this is due to this. In neurology, we first ask the question, where is the problem at? So I always tell people and my patients that neurologists are overglorified electricians. We want to find out where the electrical problem is in the central nervous system, and from that, we can then determine what's wrong. Next, epilepsy represents recurrent, unprovoked seizures. So there's a lot of things that can cause people to have seizures, one of which would be low sodium, high sodium, low blood sugar, high blood sugar, can all make people have seizures. So that's a provoked seizure. If you have a febrile seizure because you're a little baby and you have a high temperature, you can have a seizure. You don't have epilepsy because that seizure is provoked, just like alcohol withdrawal seizures could be provoked. So we look at some data, and approximately 3 million American adults and 470,000 American children have epilepsy. In 2010, that was 2.3 million, so we increased in a little over 7 years. 1.2% of the population have active epilepsy in 2015. What is active epilepsy? Active epilepsy is when the CDD did this questionnaire thing that they sent out to people, and if you said yes to having seizures or yes to taking medications for seizures, you were counted, and that's how they came up with those numbers. Let's look at Iowa compared to the states around Iowa. So if you look at Iowa, of all ages, 31,400 people have epilepsy. Okay, that's about 1% of the population of Iowa, as Iowa has about 3 million people in our state. If you look at those numbers, 4,400 are children and 27,000 are adults, people over the age of 18. What's interesting is our governor currently is wanting to reduce funding to educate people about epilepsy and to reduce funding about schools and educating schools about epilepsy when you have a large number of students in school and people don't know how to react to people who have epilepsy. If you looked at differences between sexes, I don't know what the current data is. If you look at the data from 1935 to 1984, males have more epilepsy than females. That number is probably generated because males are at greater risk of head trauma and head injury. So the cumulative risk of someone having a seizure at any one point in time is 1.3 to 3% of the population. So if I were to ask how many people in this room have epilepsy and said, raise your arm, I would be one of those people. I have epilepsy. So I'm in that 1% of the people, the 3% of the people who have epilepsy. I'm effectively treated with meds, and I look fine and normal. What's interesting about this data is that if you look here at this second statement, stigma also continues to be an issue for those with epilepsy. In 2013, 12% of the U.S. adults said they would avoid a person who has frequent seizures. I don't know what the definition of frequent seizures is. I don't know if that's 1 a month, 2 a month, 4 a month. But a lot of that comes from people not knowing about the disease and the disease state. Think of all the people that you know in your life that you've been attached to, and then think about how many of those people that you know of who have had someone in their family have seizures, and see how you feel on the inside about being close to someone who has seizures or not. What's interesting also about people who have epilepsy is that it's ineffectively treated because professionals don't recognize what represents a seizure and what is recognized by a seizure. So if you remember the videos that I showed about the two people up above, which one was a seizure, which one was not a seizure, how do you determine? And then how do we use our vocabulary to determine what's what? So the first option that we do in evaluating patients with epilepsy is we do an EEG. What's interesting about an EEG is that 50% of EEGs are normal or more in people that we think that have epilepsy. We do some activation procedures like have someone hyperventilate, we have someone get flashing lights, and we sleep deprive people before they have an EEG. And those things tend to bring out abnormalities in the EEG, and hopefully you can get something that would support a diagnosis of epilepsy. In most cases on an EEG, we don't capture a seizure. And so the diagnosis that we put with it is we say it's a normal EEG because of the absence of abnormal findings. Or we say an EEG is consistent with the diagnosis of epilepsy because it shows us it has footprints of seizures on it. But a person can have footprints of seizures and never have a seizure. So you don't treat the EEG, you have to treat the patient and the history. And so we look at a differential diagnosis for epilepsy. When we look at a differential diagnosis of epilepsy, we look at all the potential things that can make someone have something that looks like a seizure. So personally, I don't like us using the term seizures. I don't like the term seizure because the minute you use the term seizure, it makes you think of epilepsy. The minute you think of epilepsy, you say someone needs to be on a medicine to treat epilepsy. Well, that's really not true because of all the different causes. And our job in medicine is to do no harm first, and all the meds that we use to treat epilepsy with can cause harm. So we should first look at a patient and say, what's wrong? Is this due to drug toxicity? Did the person faint and have a convulsive seizure or a convulsive syncopal spell? Is it a migraine? A lot of kids have what we call a migraine with hemiparesis, so we call it hemiplegic migraine, that can present as being a seizure. People who have visual auras with migraines, a person can have seizures if it starts in the occipital part of their brain and have a visual aura and some other symptoms, and people can misdiagnose them as having epilepsy. People who have strokes can present with seizure-like activity. People who have had strokes are at risk for having seizures. Gastrointestinal disorders can present as seizures, movement disorders, and then psychiatric disorders. And this is really one that's really an interesting one, is that there's a large percentage, more than we would care to say, of people who are abused, physically, verbally, and or sexually, who developed seizures, and developing those seizures is a way in which they protect themselves from being abused. And they have what we call conversion disorders or a dissociative identity association disorder, and those can all be a cause of seizures. Those patients need to be helped. Unfortunately, we have a shortage of psychiatrists, we have a shortage of therapists to help those people, and there is a huge shortage of neurologists to understand those patients to provide them with needed help and benefits. So if we look at people with psychogenic seizures, about 10 to 45% of those patients with refractory seizures are referred to an epilepsy center or an epileptologist. A lot of those patients have non-epileptic seizures and have no way of being treated. Sometimes neurologists are not equipped to treat people with psychogenic behaviors, and psychiatrists aren't accustomed to seeing those patients, so they don't really know exactly how to treat them. So we talk about seizure types in epilepsy differential. So a person has a single event or a recurrent event, and we ask, is it epileptic or is it non-epileptic? We have this huge differential of things being non-epileptic, and we talk about epileptic events. If you look at this slide, you see these medical terms, absence, tonic-clonic, tonic, clonic, myoclonic, atonic, altered awareness, awareness not impaired, and then secondary generalized. What do these terms mean? Most people look at the term absence and they say small seizure. Absence actually is a syndromic diagnosis in someone who has brief staring spells. A person may have brief staring spells and have what we call automatisms, where they'll blink their eyes frequently. They may have lips and oral movements, and they may pick at their clothes and simply stare. Typically lasts for 10 to 15 seconds, and it's done. Happen more commonly in kids than in adults. They have a direct EEG correlate that shows 3 hertz spike and slow wave on an EEG. However, we also say, as a layperson, a person who has a complex partial seizure, which starts in one small part of the brain and then spreads to affect other parts of the brain, that they have an absent seizure because they're absent. They're not there. They're not aware. But that's a poor term. And so part of my talk, and a lot of my talk at the end, is going to be geared more on a new classification system for epilepsy put forth by the International League Against Epilepsy and supported by the American Epilepsy Society. So if we look at epilepsy in terms of predisposing factors and causes, it's sad that 65% of patients who have seizures, we have no idea why they have seizures. We have some that have vascular, congenital, traumatic, neoplastic, degenerative, infectious. But 65%, we don't know. So we talk about the definition of epilepsy, which I've already stated, so I'm going to go over this slide. And so International Classification of Seizures started a long, long time ago, and they used the term as simple partial, complex partial, and generalized. But most lay people don't understand what those terms mean. And a lot of doctors and support staff, nurses, don't know what those terms mean either in terms of what we mean by it. And so that makes these terms really bad terms to use because we don't really know what they mean. And we're throwing them out there, and so patients throw them out there. So if we look at the history of classifications, for decades, we've used this term grand mal and petit mal. Grand mal means big seizure, and petit mal means small seizure. Oftentimes, people will throw absence in for petit mal, and we shouldn't do that. And so the old terminology is partial seizures. The new terminology is going to end up being focal or localized onset seizures. And so a partial seizure is simply a seizure in which it starts in one small part of the brain and then spreads to affect more parts of the brain. Once the part of the brain is involved to where you can't communicate or interact normally, we say it's a complex partial seizure. If it keeps spreading and it crosses the corpus callosum or the superhighway that interconnects the left and the right brain, we would say it's secondarily generalized. Then we have the term for generalized epilepsy, which is seizures that start on both sides of the brain at the same time. So the International League Against Epilepsy, which is the world organization for epilepsy, has gotten together and decided that because the terms that we use seem inappropriate or confusing, it's better that we find new terms. So about 5 years ago when they got together, they used the term cognitive and dyscognitive to be simple partial and complex partial. But what does cognitive mean, dyscognitive and cognitive? So it was confusing for neurologists, so they had to throw those terms away. And so then they met again, and we talked about different things such as syndromic causes for epilepsy in terms of talking about epilepsy by what things cause it. But when you look at 65% of the people, we don't know why they have epilepsy. It's kind of hard to use that type of a classification system. So we went back to the beginnings and the root of neurology and decided that we should base seizures based upon where they come from. And so the nurses here at Mary Greeley know that when I talk to them about seizures and epilepsy, I first asked, what does a person do at the very beginning of the seizure? because that's going to tell me where in the brain it comes from. Neurology is all about where first, and then we'll explore the cause. So the new classification is very basic. It's based upon where seizures begin in the brain. Is their awareness altered or unaltered, and what other features go along with it? And so we have this problem of what does awareness mean? And awareness means that, one, I can interact normal with you, and you can tell that I'm physically aware and able to interact happily. Now, if I lose my ability to talk, but I'm still aware of what's going on, I'm aware. If I lose my ability to know what's going on even for like 5 or 10 seconds, I'm unaware. And when it comes to looking at safety issues, and safety with epilepsy is a big issue, if I lose my awareness, I then become a safety problem, because I could then fall into a fire if I'm camping, or if I'm working underneath the hood of a car, I can fall in and put my hand someplace where it doesn't belong. So these words awareness become very important. We used to say the term altered consciousness. And that was hard, because what does altered consciousness mean? Does that mean that you're out completely and you're laying on the ground and unconscious? Does it mean that there's an altered consciousness? If you're asleep and you have a spell, does it mean that you're unconscious? Or if you're asleep and you have a spell, you were asleep to begin with, you can't lose consciousness because you're already asleep. So these things all became confusing and complicated. And so the current definition or classification came out in 2016, December. And it's based upon focal onset seizures, where awareness is maintained or it's impaired, motor onset or non-motor onset, and then instead of saying secondarily generalized, if it spreads to affect both sides of the brain, you'd say focal to bilateral involvement of the brain versus saying secondarily generalized. Generalized onset means that it starts on both sides of the brain at the same time. So I like to use this example of a swimming pool, which I can't show here very well, but picture a swimming pool, and you have a shallow end and a deep end, and you have a canal that connects the two. And that canal goes from shallow to deep. In Latin, sinister is left, and dextro is right, so the deep pool is the right side of the brain. Sinister is left, the left side, or the shallow part of the brain. If you drop a pebble in the water, you'll see that ripple. A swimming pool has lane lines, and the brain, if you look at the brain and use your fist as an example, and you open it up, you say the brain has lane lines. A simple partial seizure or a focal onset seizure would start in one part of the brain, and it has to spread up and down that whole gyrus or part of the brain first before it spreads to affect other parts of the brain. And so you can tell what a seizure comes from and what it does based upon that information. Motor would go along with what you see motorically with the seizure. So motorically, what you may see with a seizure, you might see twitching of the arm at the beginning of a seizure, and you can see it spread and affect the face, and it would spread and affect the leg because it's going up and down the motor cortex. Alternatively, you could have a sensory seizure, which has no motor onset, but it starts in the parietal lobe in the sensory part of the brain, and you would feel numbness, tingling, hot, cold, or some other symptom in which the brain recognizes a sensory symptom, and you can tell what that is. Some people may have the smell of burning rubber. Some people may hear bells. Other people may see bright light. So that would be a non-motor seizure type activity. An aura could be actually a simple partial seizure or a focal onset seizure. If you read back, they talk about seizures coming from the womb and growing up over your body, and you get hot and warm, and then you black out or have this altered awareness. We'll skip that slide. So we come to this slide, and it expands things into what we see in terms of activity during a seizure. So we talk about automatisms, which are automatic movements in which a person appears to be doing something that seems purposeful, but in reality, it's a non-purposeful movement. Atonic means a loss of tone, so a person drops to the floor. Clonic means jerks, and a clonic jerk is a huge jerk, where a myoclonic jerk is a very simple, not very pronounced jerk. You can have non-motor symptoms, which would be you can break out into a cold sweat, a strange smell, feel a stomach upset. So there's all these different things that you can have. We're going to come back to this. And I'm going to come back to this because I want to show you this gentleman who came in for monitoring. And what's interesting about him is he would have these episodes at home where his wife would see him fuddling with the paper. He would just fuddle with it. She would call his name and he would answer and respond, but sometimes he didn't respond. And he had other spells that would happen to him. And so he has a localized seizure that started out with some premonitory symptom that then spread, becoming bilateral focal into a generalized tonic-clonic seizure. I'm going to throw in a little bit about first aid here. When a person has a tonic-clonic seizure, every muscle in their body becomes stiff and can't move. And so you don't breathe. If you don't breathe during a seizure, you're going to turn blue. So it's normal for someone to turn blue during a seizure. It's normal for someone doing a seizure to have a very fast tachycardia. And so if you're aware of that, then you know up front that you don't want to do anything and jump to any conclusions about a person not breathing or a person not having a good heart pace, because those things may not happen during a seizure. As a person starts to slow with those movements, you want to roll them over to their side. So if anything in their mouth falls out, because the first thing you do after a seizure, you take a deep inhalation. And you'll breathe. And I would tell you that you should wait at least 15 to 20 seconds before you were to start doing CPR on someone who just got through having a generalized tonic-clonic seizure, because they're not going to breathe and they're going to turn blue. So both patients had seizures. All right, so those of you who said both patients were having true seizures were right. The beginning person was him just fuddling with his menu, and so that was not a seizure. So anyone who said that the man was having a seizure was wrong at the time. And if you said that the woman was having a seizure, you were correct. At the time, she was having a seizure. The gentleman had a seizure after he was fuddling around with the menu. But both patients have epilepsy. Now, you had no way of knowing that. And so the most important thing about seizures is what I said at the very beginning. You first say where, so you want to stand back and describe what you see. And you should see if someone is interactive with you first. So this new classification system for epilepsy does not include everything, because there are certain epileptic syndromes and genetic syndromes that are not included within that description. Those things are still being worked out and figured out through committees within the International League Against Epilepsy. So back to approaches of epilepsy management. One, a seizure is a very discrete clinical event, and you don't know if it's epileptic or non-epileptic without an appropriate history. Always tell someone, videotape it for me and bring it in so I can see it. But even from looking at something, you can't tell if it's epileptic or if it's non-epileptic. Not all things that appear to seize need to be treated. You need to have an accurate diagnosis first. And the accurate diagnosis is from all the clinical information, and that is history, congenital history, developmental history, birth history, history of trauma, history of strokes, history of cancer. because a lot of things can cause seizures. You have to know about history if it was provoked or not. If I go out and I binge drink every weekend and I stop suddenly on Sunday and every Tuesday I have a seizure, it's probably an alcohol withdrawal seizure. If I go out and I'm smoking pot and I don't know what my pot is laced with, I can have a seizure because of smoking the pot. Now, that being said, cannabidiol is very effective at treating seizures. The problem with cannabidiol and its treatment of seizures is, number one, we don't know the dose. Number two, we don't know drug-drug interactions. So actually, to be honest with you, it's dangerous right now for us to go out and dispense cannabidiol because there's more things we don't know about it than what we do know about it. But it is effective at treating some seizures. So the workup and seeing someone with epilepsy involves a good history, a neural exam, family history, routine blood workup and evaluation, determine if someone has a toxic or metabolic cause for their seizures. We do an EEG. Sometimes on people with disabilities, the EEG has to be done with sedation. The problem with doing an EEG with sedation is all the medicine that we use to sedate people with is used to stop a seizure. So by giving someone sedation to have an EEG, you decrease their risk of them having a seizure. Currently, what I do here is I'll admit someone sometimes to the ICU and give them one of the anesthesia drugs that does not affect brain activity and have them have a seizure with sedation. I haven't done it that often, maybe 6 or 8 patients, but that's one way of getting a good EEG on someone who has epilepsy, and if you give them sedation, we'll make it go away. Sometimes you have to admit people to the hospital for 4 or 5 days for a continuous EEG to either get an abnormal EEG finding or to capture a person's clinical spell. Now, what's interesting about that is the description of the clinical spell is very important. If they come in and they have an atypical spell, not what they're having at home, it doesn't help you. You have to capture the habitual spell that a person has at home and say that that is or is not epileptic. So we come to approaches to management. And there's not really enough time to talk about management of epilepsy in terms of all the medications that are new since 2000 that we're using in our hospital, or that some physicians are using and some physicians are not using within our hospital. But the goal of treating epilepsy is for someone to be epilepsy-free and control all seizures. That means no breakthrough seizures. That is not possible for about 33% of the population. So if you remember, the number of patients in Iowa who have seizures was 31,000. 1/3 of those patients are refractory. So 10,000 people in the state of Iowa have ongoing seizures that are untreatable. And that's actually sad, because if those patients had better treatment, and if we had better treatment, we could potentially cure more people with epilepsy. The other goal is to have no adverse events. All the drugs that we use to treat epilepsy cause about the same symptoms. They'll make you sleepy. They can make you dumb. They can make you walk like you're drunk. They can cause problems with your liver. They can cause problems with your bone marrow. So they can kill you. Because the medicines can kill you, they aren't really that safe. They have a very low therapeutic index, meaning that small amounts of the drug being toxic can be toxic to your body, and you can have a premature bad outcome. Drug-drug interactions, we would like to have no drug-drug interactions. A lot of the medicines that are first-generation drugs interfere with medications. So I have a 25-year-old girl who has refractory generalized epilepsy. She's on Dilantin and methotrexate. Now, most people have heard of Dilantin. Probably very few people who have ever heard of methotrexate or Dilantin to treat her seizures. So she got pregnant, had to go on this combination of meds to stop her seizures. After her first pregnancy, she had a DVT, got worked up, has 2 clotting factors against her to place her at big risk for recurrent DVTs. Her hematologist wanted me to take her off Dilantin because she had to put her on Coumadin. Well, off Dilantin, she failed 5 drugs and had to go back on Dilantin, and she had to go on, I'm blocking on the name, Lovenox, thank you, for her seizure. So she's on Lovenox every day to treat her seizures. She's in her second pregnancy. I just saw her yesterday, and she's doing actually very well. Once she delivers her baby, her second baby, the problem's going to come up. She has to come off Dilantin. And the question is, what med do I put her on? She's failed everything else. So she's not planning on having any more children. But, these things happen. And so the idea is I'll probably put her on a medicine called Felbamate. Felbamate is a medicine that was put out in the market in 1994. By 1996, 20 to 30 people died on it from either liver failure or bone marrow failure. People who are epileptologists continue to use it. And actually, it's a very good drug, but it can cause bad side effects. But I think that's a medicine that this lady is going to have to go on in order to treat her maximally so that she doesn't have DVTs and pulmonary embolus. The whole idea behind treating people with epilepsy is to give them an improved quality of life. You notice that 12% of the population in the United States does not want to be around or associate with people who have frequent epilepsy. I'm not sure what frequent means, though, but that's not just regular people, that's all people. We like to optimize growth and development in kids and cognitive function. So we want to look at the quality of life, not just living. Most medicines we use to treat epilepsy with will make you sleepy, tired, and drunk. That gives life without meaning. We want life with relationships. We want someone to be able to interact with other people. And we want a person to be able to interact within a community. And if people are afraid of you, you can't interact with the community. So selecting anticonvulsant medications, we want to look at absorption, how the med distributes in your body, its metabolism, and how it's excreted by the body. We prefer monotherapy versus polypharmacy. If you were to look at the data here, this is Kwan and Brody's data that's been repeated and duplicated in multiple other studies. If you take 100 people into this room and all 100 people had epilepsy, the first drug I take off the shelf and give you, I don't even have to get much of a history, just take this drug. 1/3 of those patients out of the 100 will be seizure-free. The second drug I take off the shelf and give it to you by itself or in combination with the first will make 47% seizure-free. The third drug by itself or in combination with the other meds will make 64% of the people seizure-free. Unfortunately, that leaves 33% or a little bit over that who have refractory epilepsy. Of that number of patients, about 12% can become seizure-free with some form of epilepsy surgery. Another 8% to 10% will become seizure-free by some current investigational drug on the market. 8% to 10% will continue to have refractory epilepsy. And so in approaching seizures and treatment of seizures, we have to know the seizure type. It's helpful to know where in the brain it comes from. If you know where in the brain it comes from, if it's not coming from eloquent cortex, the part of the brain that makes you who you are, then you can have epilepsy surgery and remove it. If it's not a huge area of your brain, or if you're less than, let's say, 15, we can do a hemispherectomy and remove half your brain, and you can still function with half your brain if it's causing you to have seizures. So if we look at seizure anti-epileptic meds through the history, we have what we call first-generation drugs, phenobarbital, which came out in 1908, Dilantin, 1937. In the 1950s, ethosuximide came out. It treats absent seizures only. Carbamazepam came out in 1974. Depakote, 1978. What's interesting about Depakote that came out in 1978, it was on the market for 2 years, and then a lot of babies less than 2 had severe hepatic failure, and it was withdrawn from the market. And then it came back out on the market, and it had a big black box label saying not to be used in people less than 2. Felbamate came out in 1994. It was a fantastic drug. It was known as the gift to mankind for treatment of epilepsy. But as I said earlier, within 2 years, it was withdrawn from the market, kind of sort of because of these number of deaths. Gabapentin came out in 1994, 1996. it's not used as much to treat epilepsy. It's primarily used to treat pain. The problem with gabapentin is you have to take it 3 times a day. Lamotrigine came out in before 2000. So then Keppra came out in 2000, and since Kepra's been on the market, we'll go to the next slide, we have, since 2010, 6 new drugs that's come on the market. One of those medicines is Exagabine, or Ritagabine, or Potiga, which is being removed from the market this summer because it makes people turn blue. And the company's having a hard time selling it. I'll stop there and I'll answer questions. I talked to the people who run Grand Rounds, and I'm going to give another talk at a later date and time. I'll show some more videos of that talk about seizure classification, and I'll talk more about medications. Yeah, Mike?
Yeah, Dave, do you have any comments about, I've heard a very ketogenic diet for refractory seizures?
Oh, very good. So a ketogenic diet, which is an example of a ketogenic diet, would be the following. A cup of lard and 2 scrambled eggs would be your breakfast. So it's a very, very high-fat diet, high-protein diet. Any sugar that you go on ruins a diet. So it's a very effective, good diet for little kids. It can cause kidney stones, so that's a problem with the ketogenic diet. If you're an adult and you had refractory seizures, I would tell you to go on the Atkins diet. The Atkins diet is a form of a ketogenic diet. It just isn't as far. But it's very effective at treating epilepsy. I have that in here, there. Other questions? I thank you very much for attending, and I look forward to seeing you again in the future. Thank you.